This is a lecture about the posterior segment intraocular foreign body and the dealing strategies. The ocular trauma terminology addresses the intraocular foreign body. Who is at risk? Approximately 80% of injured persons are males. What is the source? The source is blunt objects like rocks, fists, wood, branches, baseballs, champagne corks, work-related injuries, sports and recreational activities, hammering on metal and nails. What is the site? The workplace has been the most common site. Domestic injuries has been increasing. We have Birmingham eye trauma terminology. We have injuries. The eye injury either open globe or closed globe. The closed globe injury is further classified into contusion and lamellar laceration. The open globe injuries is further subdivided into laceration and rupture. The laceration include penetration, perforation, and intraocular foreign body. We have some terms and definition in eye trauma based on Birmingham eye trauma terminology. The eye wall is the sclera and the cornea. We have closed globe injury, no full thickness wound of the eye wall. We have open globe injury, in which there is a full thickness wound of the eye wall. We have contusions, in which no wound. The injury is due to either direct energy delivered by the object or it changes in the shape of the globe. We have lamellar laceration, partial thickness wound of the eye wall. We have rupture, full thickness wound of the eye wall caused by a blunt object. Because the eye is filled with incompressible liquid, the impact results in momentary increase in the intraocular pressure. The eye wall yields at its weakest point. The actual wound is produced by an inside-out mechanism. We have laceration, full thickness wound of the eye wall caused by a sharp object. The wound occurs at the impact site by an outside-in mechanism. We have perforating injury, entrance wound of the eye wall. If more than one wound is present, each must have been caused by a different agent. Intraocular foreign body, retained foreign body object inside the eye. Perforating injury, which is entrance and exit wound. Both wounds caused by the same agent. The intraocular foreign bodies are common and serious problem in traumatic ocular injuries. They occur in up to 40% of open globes. Put an eye at risk of infection and retinal detachment and metallosis after intraocular foreign body. The intraocular foreign body must always be ruled out whenever periorbital ocular tissue damage or wounds are apparent. The intraocular foreign body could be metallic or non-metallic, could be toxic or non-toxic according to the nature of the substance. The toxic metallic including iron and copper. The non-metallic toxins include vegetable matter. And the non-toxic non-metallic include glass and stone. The intraocular foreign body is associated with ocular damage by several factors. First, the entrance wound. The intraocular foreign body possesses certain energy to perforate the eye. The length of the entry wound is predictive of the risk of the retinal damage. The shorter the wound, the less energy to be lost during penetration. Another issue is the mechanical intraocular damage. Little or no damage is expected if the intraocular foreign body has completely lost its kinetic energy upon entry. The primary impact may be followed by additional impaction. The inflammation and the chemical complication are another issue. The drosses also Intraocular foreign body related corrosion is caused by interaction between trivalent ions and proteins in the eye. The cytotoxic effect of the iron released inside the eye with the subsequent enzymatic libration lead to cell degeneration. The ferric iron is thought to be toxic by generating free radicals. Again, remember that intraocular foreign body can elicit ocular damage by several mechanisms. Xerosis is something to be addressed especially. Xerotic changes include the following clinical findings: chronic open-angle glaucoma, brownish discoloration of the iris, dilated non-reactive pupil, yellow cataract with brown deposits on the anterior capsule, pigmentary retinal degeneration with visual field loss, and visual impairment. The clinical diagnosis is confirmed by characteristic ERG finding, including increased A wave initially and progressive reduction of the B wave subsequently. We have also chalcosis caused by copper intraocular foreign body. Causes rapid sterile endophthalmitis-like reaction including corneal and scleral melting, hypobion in the anterior chamber and retinal detachment. Copper tends to deposit in the membranes and causes destruction by increasing lipid peroxidation. The typical clinical findings include greenish discoloration of the iris, greenish brown colored cataract with spokes of copper deposits, copper particles in the vitreous and copper particles on the retinal surface. Diagnosis and localization of the foreign body is something fundamentalistic. It includes history, ocular examination, radiological examination, ultrasonography, metal locator, and trans-illuminations. Careful ocular examination, especially if we have a medico-legal conflict, including visual acuity, pupillary action, intraocular tension, iris color and lens status. And don't forget open globe injury, incarcerated intraocular foreign body, and posterior segment injury. Plain film radiography. The shape and number of metallic foreign bodies could be identified by a plain X-ray. Localize the foreign body. It detects associated orbital wall fracture. A negative plain film may make more expensive and invasive tests unnecessary. Intraocular foreign body. The question is the foreign body inside or outside the eye? What is the proximity of the foreign body to the sclera? We have radio-opaque markers, contact lens with radio-opaque markers in the 4 quadrants. We have limbal ring devices. We have subtenon injection of air and contrast media. We have also CT, computed tomography. It is the standard diagnostic test for imaging the traumatized eye and the orbit. It can detect metallic foreign body less than 1 millimeter in size and less radiolucent objects of a slightly larger size. Always insist on the thinnest possible slice, less than 1.5 millimeter, through the orbit, and in case of a suspected metallic foreign body, request overlapping slices. Both an axial and coronal orientation is needed. The MRI, due to its potential for tissue damage from the movement of the foreign body in the intense field of the magnet, MRI should not be used if the intraocular foreign body is thought to be a ferromagnetic. The role of ultrasonography. It aids in localization of the foreign body relative to the ocular coats. It demonstrates the soft tissue changes. Glasses and metallic foreign bodies are very reflective and appear as bright areas on the B scan. However, it has a poor specificity. Now, an intraocular foreign body is present. How to manage? How to interfere? How to put a strategy? It depends on the time, location, nature, size, and lens status. we have a question: delayed versus immediate interference, and the route and instruments used for intraocular foreign body extraction. About timing of surgery, the presence or absence of clinical endophthalmitis, it affects the time of surgery. The stability of the patient for an extended surgical procedure, and the availability of a well-equipped operating room. Immediate intraocular foreign body have some advantage. It decreases the risk of endophthalmitis and the toxicity from the intraocular foreign body material. It decreases the rate of proliferative vitreoretinopathy, a single procedure under anesthesia with all its attendant risks. Delayed intraocular foreign body removal also has some advantage. It allows better integrity of the repaired laceration and less wound leakage. It allows less severe anterior segment pathology, better corneal clarity, and hyphema absorption. It gives time for vitreous detachment to occur. It gives time for resorption of vitreous hemorrhage, liquefaction of the clot, and decreased bleeding. It is associated with decreased choroidal swelling.